that's offered and treated. Professor Greg Crawford is a senior consultant in palliative medicine, the Director of Research and Education at the Northern Adelaide Palliative Service, Professor of Palliative Medicine and Discipline of Medicine at the University of Adelaide. He has a terrific panel which he'll introduce to you, but I invite him up now. Would you please welcome Professor Greg Crawford.
Thank you. Thank you very much, Virginia. I'll ask my panel to come up while I'm talking. We've got an hour to talk about palliative care as being core business for aged care and what that might look like. This is an interactive, streamed event, and so I'd like you to make sure you've got your devices out because I'm going to ask you some questions as well, and I'd certainly like you to be able to ask some questions of the panel. I'd like to acknowledge our sponsor, Decision Assist. Decision Assist is a national program for aged care staff and health professionals, enhancing palliative care and advanced care planning for older Australians. The program offers resources and services in advanced care planning and specialist palliative care for aged care and general practice workers. And you can find more about Decision Assist and access this online. There are educational information, fact sheets, and certainly visit them at booth 26 in the exhibition area. So I'd like to introduce our panel first. You have their biographies on your apps, but just as a brief introduction, working across the room we have Pat Sparrow, who is the Chief Executive Officer of Aged and Community Services Australia. Marcus Riley, who brings his chairmanship of the Global Ageing Network, but also as a CEO of BallyCara, a charitable organisation that provides services to older people in Queensland. Mary Schumacher is our Kiwi in the middle. Mary hasn't told you much about herself, but she started life as a social worker, has been a CEO of Mary Potter Hospice in Wellington, and is now, or she was a manager, now she's the Chief Executive of Hospice New Zealand, a peak body for palliative care. Ilsa Hampton is the CEO of Meaningful Ageing Australia, so it's pastoral and spiritual care is the focus. And Susan Emerson is an old mate of mine. Susan is the Director of Care Environments and Service Strategy for Helping Hand Aged Care, which is a large organisation, particularly here in South Australia. So could we go to the first poll? And I'd like to know first where you work or volunteer. So get your apps out. Is it aged care, specialist palliative care, both, other or not applicable, please? So we've got a lot of specialist palliative care there, haven't we? That's interesting. The other one I'd like to know is, what is your discipline? We've got that one lined up too, I think. So I'd like you to think about whether you're a manager, a care worker, a registered nurse or higher qualification or other nurse if that doesn't fit your description, medical, allied health, volunteer, pastoral care, other or not applicable. Let's just see. We all have some idea of what the gender mix is in the room, but let's see what sort of work we're doing as well. Is it not letting you go through? That's a bit mean. We always blame broadband for that, don't we? I'm sure it will in a minute.
NBN.
Yeah, something's happening.
There we go.
Okay, so what does that tell us? A lot of nurses. A fair number of doctors, really. Pastoral care. Where's pastoral care, Ilsa? Yeah. No, the other dark green. No, that green.
0.4%.
0.4%, going lower. Excellent.
Yes, that's right. They're dropping like flies there.
Yes. But did they know the meaning and feel good about it? Okay. So thank you very much. That's a start. Let's think about your questions, but I'd like to hand to the panel first and ask them, what would you want if you were to spend your last days being cared for by aged care services? What are your own personal preferences? So Pat, start us off.
Which I think is a really hard question, and I think as the previous discussion actually showed, one that might change. So what I imagine sitting here as a well person that I would want is that I would want to be at home. So my choice would be to have aged care at home, for it to be as unobtrusive as possible, just to be able to come in and do the bits that I needed. But to make sure that my family members or friends or whoever it is that are caring for me towards the end of my life actually can be who they are, rather than take on the role of nurses or carers. And some of that's from personal experience with my father at home, who was horrendously embarrassed by having to have his youngest daughter assist him go to the toilet, or when there was an accident. So for me, that's front of mind. But I don't rule out the fact that depending on what those circumstances are for me, it may be that I need to enter a hospice, or I may be in residential care. And if residential care is my home, then that is where I would want to stay. And the same rules would apply. Unobtrusive care that's there when I need it, that allows my family members and friends to be family members and friends. Thank you.
Okay. Marcus, yeah.
Thanks, Greg, and good morning, everyone. For me, it would be the same as any stage of my life. So there'd be three factors for me. One would be to be in control. So that means it's as planned as possible, which would allow me to determine the location, so whether that is in my care facility or whether it's at home. To be positive, so that would mean my people are around me, and if it is in a facility, staff that I have a relationship with and they know me. And the third element would be my passions, so things like music, sport, food we spoke about earlier this morning, those things would need to be a part of it, and fun and laughter.
Fun and laughter, excellent. Mary.
Kia ora, everyone. It's such an important question, isn't it? And when I've thought about this, I've thought about what matters most to me, and it would be compassion and kindness and tenderness. And I think that's irrespective of setting, and to be with people who know me, truly know me, and meet me at a heart-to-heart level. If you're in a facility, or if you're in a hospice or a hospital, we just know that tiny little bit about a person. What I would really want is for someone to know and appreciate really who I am and all that I am, and bring that to the care that they provide for me.
Hi everyone. For me, it all starts with what's the process. So I'm picturing, it's residential aged care. So first of all, there's been a process in selecting an organisation where the physical environment is really supportive of people. There's access to nature, and there's plenty of space for personal stuff and one's community in different ways. And that the kind of whole process of engagement, entering that environment to begin with, has been a really supported one. And then it's around the nature of the staff, the way that they're relating, and as you're talking about, Mary, that compassion and kindness, also access to medical expertise, and people who have walked this road 1,000 times before, because it would be new for me and my family. So having confidence in them, but also the space to talk about the things that we're afraid of or that are bothering us, and knowing that there is someone available to have that conversation, whatever their title is in the care mix, that there is that space and opportunity to safely talk about what's going to happen when I go, things, unfinished business that I might have, those kinds of things.
Good.
Thanks, Greg. Hello, everybody. It's a hard one. I'm going to picture myself in residential care, because I can't assume that anyone will necessarily be there to help me. And I'm going to picture myself in the sort of places that I like to create for people who we provide services to right now, which is a very space-oriented around access to fresh air, to gardens, to connection with community, to be able to see people living their lives still. And of course, in the background, I'm expecting this good quality healthcare from an interprofessional team. But I know that actually the people that make the most difference, and I've got a nursing background, are sometimes the housekeepers, the cleaners, and the food services staff. So I want to be in with them, because they might help me look after my pet, because I'm going to be in a pet-friendly place, and they're going to be really welcoming to children, and they're going to have a lot of fun. And I think we can learn a lot from paediatrics. I've got a nephew who is 3 and has survived a very severe brain tumour. And he had the most wonderful, wonderful medical care here at the Women's and Children's Hospital. But actually the people that broke our heart and made us laugh were the clown doctors and the music therapists. So I'll be looking for really good interprofessional care and a good sense of humour in a very serious time.
Good. Yes, please.
Just a comment. The ladies mentioned compassion, which I think particularly in the aged care setting is such a crucial element we need to focus on a little bit more, both in terms of the person themselves and our staff. We are all aware of burnout in our workforce in aged care, particularly in terms of end-of-life care. And I think if we can better develop the understanding in our staff of the difference between compassion and empathy, and I think the empathetic approach that a lot of staff naturally take on leads to that burnout, whereas a compassionate approach that can be an improved situation for the staff, as well as obviously delivering a better outcome for the person themselves.
As somebody who left their hand up with Magnolia's questions, having actually enacted the written advanced care directive, the thing that's most important for me is that I've educated my daughter that it's got to be whiskey from the top shelf of the shop when she goes in. That's a lot of blue sky dreaming, but does it really happen? And what are the challenges? And in particular, can I ask you, given the shift that's happening in many aged care facilities to less registered nurses, less skills perhaps, and they're not all as well equipped, how can aged care providers actually provide good palliative care? And in a minute I'm going to ask you how many of you actually had any training about palliative care. So does somebody want to say...
No.
Yes?
Can I perhaps, as the peak body, I actually think we need to correct that. That's not actually true that there are less registered nurses. In fact, the use of registered nurses is increasing. If you look at some of the benchmarking surveys, nearly all aged care facilities would have registered nurses on staff. I know that there might be a difference between what some family members might perceive to be enough, but most nursing homes and residential care facilities do have registered nurses. The number of hours of registered nurses is increasing. But what providers are looking for and what they are able to do is to make sure that they have the right level of staffing and skills mix. And so you will see, other allied health professionals, care workers, the whole range across the workforce. So it's not quite right to say that the registered nurses are decreasing. And I just think that's an important thing to put out there right up front.
Thank you. Susan, as a registered nurse, would you like to add something?
Oh, thank you. Yes, certainly. In preparation for today, we're very fortunate to have a nurse practitioner in palliative care in our team, and I met with Jane. Her role is very, very grounded, very connected to people, largely in our metropolitan services. And, in our conversation, Jane said, in aged care, we nurses are masters, jacks of all trades. We have the most comprehensive role and a complex role. We're also masters, but we're not necessarily specialists. And I think not all of us are specialists. So Jane's role is a linking one. She's often an advocate, and she helps the nurses to advocate for what they think is going to be best for patient or client outcomes, or resident outcomes, as we say in aged care. So I think that those partnerships and support for registered nurses and all staff actually interprofessionally is key, and linking to other services in the community. We are not an island. We are a part of the community, and we are... we don't own people's lives. Our residents and clients are still part of that wider healthcare community. So I think a way we can improve is to enhance those partnerships and connections, and really recognise the value of what nurses can provide in residential aged care.
Yeah.
Greg, if I could just also put in there, one of the other challenges is around people's level of comfort with talking about death and dying, which often then relates to some of those deeper things around their spirituality. Who have I been? Who am I now? Who do I want to be? What's my legacy? Those kinds of things. And we do find, whilst some organisations do some beautiful palliative care, there are some real barriers, even amongst care staff. So we run some education and training. In a recent example, we were running some sessions. Actually, we offered a session with families about death, dying and hope, just an open morning tea. And then we had a session with care staff and others in the afternoon. And the feedback we were getting is that the care staff were so afraid, they were avoiding, when they knew that a resident was dying, they were actually avoiding the family members when they came through, because I was just so afraid to engage in this stuff. And actually, interestingly, for the families, the main thing that came up for them was not so much about the future death of their loved one, but it was the fact that their loved one was entering residential aged care was the thing that they needed to talk about the most. So there's a whole lot of process stuff that I think we can support organisations to do better, which then goes back out into communities as well. And we see again and again, like in that previous presentation, doctors and others have trouble with these hard conversations. Families have trouble with these hard conversations. So yeah, it's got to be a multi-pronged approach, but I think a whole lot of preparation can occur in the workforce, but also in our communities and in that entry point as people are engaging with services. It's not sit down and, okay, welcome to our facility, what's your funeral plan, which does happen, unfortunately, still in some places.
And then the next one is, and have you got to do your advanced care?
Yeah, that's
right.
Now? Yeah, so just sign here. So it's not that, but it's just gently starting things that get us a little bit into that territory, back here, so that you can step your way towards it, so everyone's in a better place to have those hard conversations, as they're needed.
And I was just going to say, in support of what Ilsa's saying too, we are seeing people coming in and dying quite quickly in lots of occasions. So we're certainly many organisations are having conversations about how we can accelerate the good connected relationships, how we can get past some of the bureaucracy and the paperwork and the documentation and the stress associated with asset testing, for example. And we are seeing an increased use of respite because the relationship is a simpler one in terms of finance and paperwork, but it's an interesting trend emerging. How can we... we have had residents with us for less than 24 hours. Now, that says something about where they've come from as much as it says about where they've died. But we're seeing this more and more. So accelerating that and getting to the essence of what the person wants and what their family needs is key, I think.
And I think that's part of, what we're seeing is changing nature of residential aged care. So it used to be, I don't know, I think most of us had our hands up for over 40, so I'm sure many of us will remember this. I mean, residential care facilities used to be built with car parks because residents were driving in and out. That's just not the case anymore. People do go in much older with more complex health conditions. And what we're also seeing is that there is much more shorter term, not just in terms of palliative care, but also people needing to be able to go into residential care for a period of recuperation or reablement to be able to go back home. And the system isn't well set up for that. So you can see that the way that the system is structured is for people going in for longer term, and we do need to look at how we make it easier for people who are entering essentially for palliative or end-of-life care to have a better experience.
So what are the things that need to change? Is the education right? Have you got the skill mix right? Are there linkage of problems?
Greg, I think it's such an important point. Some of the work we've been doing in New Zealand has been focusing on that relationship between specialist palliative care and residential care particularly, and actually working together and identifying what the challenges are and then coming up with a plan. And one of the things that surprised us when we truly started to engage with our colleagues in residential care was that from a nursing and medical perspective, they felt that they had the right support, but where they really wanted to see support was around the psychosocial, spiritual aspects of care, not only for the residents, but also for their staff. Because as you rightly said, they're doing a lot of palliative care, a lot of people are dying, and the grief and loss and the need to address that and the pain and suffering that the staff are experiencing. So that's where we've been putting our energy, not really where we had expected to put the energy.
And whose responsibility is that? Is it the facility's responsibility? How would you make that happen?
We've had some funding to put, so we've co-designed what's needed in the facilities, and then we've funded that to happen. So, but it requires a true collaboration and partnership.
Yeah. And so, it's pastoral care, spiritual care, the bigger psychological issues are really important, but I don't think we've even got it right about medications and after-hours reassessment. Do you think there are some things that we could improve in terms of access to medicines, appropriate staff to give those medicines? And what about when something might change? How responsive are our systems?
We could certainly be more nimble in that way. We have a research and development unit, and we're doing some work. We're doing a number of pieces of research, one on prevalence, one on reducing polypharmacy and looking at pharmacy supports and working more closely with pharmacists, because we know some of the medications are difficult to get out of hours or without established relationships with specialist pharmacists. We are seeing an increase in the use of subcutaneous medication, and the number of S8s are quite high. So when I'm designing a facility, I'm putting more DDA cupboards in aged care facilities rather than taking them out. So we often do multiple counts in multi-storey. There's some really some great logistic challenges that need to be considered when prescribing S8s, for example. I know titration models are changing a bit, but there's a lot of labour involved in administration, and if you are the registered nurse in charge working with a team who may or may not be registered nurses, there's some challenges there. I think we're seeing more impress, we're seeing more nurse-initiated medications, and we're certainly seeing our nurse practitioner assisting with expediting changes in helping us with sort of linking with others to have medications reviewed. Could keep going, but I won't.
Okay, and so let's ask you, was palliative care part of your primary qualification? Let's do a poll and see how many of you actually, in terms of you actually thought that you got it. And here we have that there's a lot of red no, isn't there? So I would hope there's been a change at the baseline for our undergraduate and training courses for nurses. I certainly know that for medical students across Australia, there's a lot of extra effort going, but I think it's probably patchy. I suppose the dominant workforce in aged care facilities are personal carers, would that be right? Mm-hmm. Can we hear something about how you become a personal carer and what skills you might have? How safe is it to talk about this meaning of life and death? And
okay. Again, this is a big question. I did speak with Helen Loeffler, who's our student facilitator. We do support about 1,400 students a year at Helping Hand, and I'll talk about care workers, but we also work with lawyers, engineers, physiotherapists, dietitians, speech pathologists, so I think that there's an interprofessional question there around curriculum. There has been a change to the Certificate 3 curriculum. Palliative care is no longer an essential core subject. However, it is often selected as an option by students who want to come and work in aged care. We are seeing a little bit of a change in the Certificate 3 students that are coming to us as part of their training. And we are finding that we have deliberate and determined conversations with them about the fact that aged care is a place where people live. It's actually a place where people come to have the best time that they can, and that it might be it is their last community often. And we do have to prepare them for the fact that people do die, which seems interesting because you think that the way the media talks, that aged care is these sort of misery hotels where everybody dies rather rapidly. But we actually do have to spend some time with students to prepare them and to give them support, to have conversations with us if they're struggling. Yes, I think we find that by working with schools and universities in partnership, we are able to influence the curriculum and really change the negative perceptions of what aged and community care is, because it is an amazing place to work in a very holistic way. It's essentially a whole of life. We're dealing with people at that complex part at the end of their life, but it's just fantastic, and many of our students leave with a very, very different perception and understanding of future career options. I just noticed today on Facebook that one of our dietitians started out in paediatrics, as did I, and I think aged care, like paediatrics, is a fantastic holistic place to be as a professional or as in any kind of role, and I think that the best thing we can do is to improve people's understanding of what actually goes on and encourage them to consider careers in this area.
good, so it's the dinner party conversation, you're just an aged care nurse, is that not as good? Is there stigma in all of that still?
Aged care generally.
Definitely was for me as a social worker. When I got worked with older people, my colleagues, when I finished my master's, said, "So couldn't you get a proper job?" So certainly, I'm hoping that's changed.
Yeah,
but
it sadly plays into a broader issue that I think we have, which is discrimination against older people generally. So therefore we don't value our older people, and we don't think aged care is the important work that it actually is.
So Marcus...
Sorry, Greg, just coming to your original question though, I think a lot of what we want to see develop in our people is that interpersonal skills, the soft skills, if you like, that we've touched on already, and ultimately that falls to each provider to develop and support their workforce and grow them professionally and personally, if you like. So, and that's obviously done to varying degrees, and that's why we'll see a range of standards in terms of how palliative care is delivered, because there'll be a difference from one place to the next as to how well that workforce has been nurtured around those soft skills, those interpersonal skills.
Yeah, soft you call them, but the ability to speak, to hear, to listen, to hear what's not said are really important. And when people are near the end of life, for my patients, they are high wired up, and every word can count. Are there some international things happening that would be that we can learn from in Australia?
A couple of thoughts there. One, no one place has all the answers, or one system has a perfect way of doing things. I think the learnings really, Greg, around the cultural aspects that we can learn, particularly in some of the less developed countries perhaps, or I'm sure Mary might share some of the importance of traditions with the Maori culture as well. They've been the big learnings for me involved in a global network that, not one country or one system has all the answers, and there's a lot of cultural learnings that we can take from different places to benefit our own societies.
And we live in a multicultural society. There must be lots of challenges. So can you tell us a bit about how New Zealand's managing?
Well, there are a lot of challenges, and I think it's something that we're grappling with, but we do have a commitment to the Treaty of Waitangi, which is our founding document with Māori and the Crown. And I think that allows us to go back to basic principles. And when we think about palliative care and how we work with Māori, we have some guiding principles. We don't get it right, but some of the good things that are happening all the time, some of the good things that are happening is that we're getting some good research into Māori's experience of palliative care by Māori researchers. There is a Māori model of health that we have used as the basis of our last days of life guidelines. And that is focusing on the spiritual, physical, emotional, mental needs of people. So there's a very strong alignment with Māori belief systems and palliative care. So when we honour those, and our view is that if you get it right for Māori, you tend to get it right for everyone else. So we are learning that.
So what about in Australia, though? I think what's the culture of an organisation and our culture and the culture of the people who are the carers and the recipients, the residents, there must be some challenges there.
Greg, I think too that the one group you didn't mention in that little list was families, and one of the things I'd certainly like to promote in this conversation is better education for the community around the value of a good death. And I know everyone in the room is going to know more about that than I, but we see it heightened in aged care because there's so many complexities, and the dynamics we see in families are just unbelievable. And all these things are coming to the fore at the end of this mother or father or grandparent's life. And we can see the value of a good death with some of the things that people spoke about at the outset of this conversation, and the benefits for the families in particular following the death versus the opposite, where some things didn't go to plan, or some people weren't involved, or there wasn't time spent, or whatever. I think if we have a greater awareness around the community in terms of the importance of that real end-of-life stage, then there's better participation prior to that end-of-life stage and a better result overall.
Good.
Some of that comes back to a workforce who are equipped to be able to have these complex conversations. So I think, it is about, at the moment, what happens at the organisational level around the development of people. It's something we've raised with the Minister for Aged Care, is that actually people need to be formed to work in aged care. It's not just a skill-based, learn how to move this trolley from here to here or feed in this certain way. It's a vocational thing. It actually has to involve your whole person in order to be able to do it really well. So I think people need to be formed for the work, and then the organisations can enhance and build on and support that formation so they become better and better at what they're doing. And that then makes, if you have that formation happening, people are more able to be more flexible. They're not so kind of rules-based or task-based in what they're doing. And so then when you meet complexities in families or cultural situations, you're better prepared to be able to respond flexibly, you know, as needed.
And so what are the barriers? There must be lots of barriers to actually make that happen. You know, are wages, are registered nurses paid differently in aged care facilities? Is there time for the training and, you know, is there any resources and money for this?
Look, I don't know if I can answer that pleasing everybody, but I was tempted to say when Ilsa was speaking that if you think about residential aged care, it really is an accommodation option. Now that might seem strange to people, but it really is an accommodation option for people who are living their lives and who may or may not happen to have a degree of complexity around them in terms of their health as well. The maximum funding we receive for any resident in aged care through the aged care funding instrument is $212.06 a day. Now, I don't know how much you know about budgets in other settings, but that's not an enormous amount of money to provide extremely complex care. So what we need to do is to work in partnership with others and consider residents as connected to those other parts of the health service. Yes.
Can I add? I mean, on the wages piece, I think it's variable with different providers and what they pay and how they can structure and how they do that. But there is work occurring at the moment that's looking at what should residential care funding be in the future.
Yeah.
Largely at the moment, the government's saying they want to do that within the existing funding envelope. But they are looking at, is the way that we fund aged care currently the best way to do it, which is, as we're saying, a dollar amount per day based on a certain characteristics of an individual resident. There's a report out at the moment by the University of Wollongong which is proposing some different models, and that discussion is going to be really important. And through that discussion there has been consideration of, does the current funding instrument actually acknowledge and support palliative care as well as it can, and what might it look like in future? There are just costs to opening the door in residential care and to having it staffed. And would it be better to have some fixed and variable models? But the palliative care issue has been alive in that debate. You can actually claim under the ACFA some additional funding at end-of-life care, but many providers actually don't do that. So providers would say the system for funding of palliative care within what we have currently doesn't work well. So we're really pleased and working towards saying, how can we have a better funding system?
And there has been an announcement recently, Pat, of $8.3 million over 3 years for 2017-2018. I think it might have even been mentioned at the conference for palliative care in the community too. So there are lots of...
Which is really important.
And the government provides a lot of grants that
That's very
support
true.
investigation
And I think
nationally.
it's a theme that came out before that I want to make sure we don't lose, which is that I think there's a view that when people go into aged care, particularly residential care, sometimes even home care, somehow they lose their right or ability to access anything else that's provided in the community.
And be a citizen.
And I actually think we need to sort of turn that around. Just because you're in residential care doesn't mean that you shouldn't be able to access specialist palliative care or any other mental health services, for example. So I think we need to sort of stop saying aged care and being old, you go into aged care and that's it, you can't access anything that the rest of the general community can.
So do you find that sometimes some facilities don't get specialist palliative care? Are there areas in Australia where specialist palliative care teams won't go and visit people in residential care facilities, mental health teams? Are you, in your facility?
Yeah, I think it's very much region by region, Greg, and when we talk about improving the system, I think a part of that has to be identifying the gaps or what's absent location by location or region by region, whether it is the lack of effective partnerships in a health network in that area, whether it's workforce, whatever those gaps might be. So in our particular region, we've got a really strong palliative care team at the Hospital and Health Service, and they connect very well with the aged care facilities, but I know in other regions that's not replicated. So immediately you've got that inconsistency, so you're going to get an inconsistent result for the care recipient.
I've certainly heard somebody use the state-federal dichotomy as a reason to obstruct care, which would be terrible, I think. So we've had a question about advanced care planning, and that's often, one of the boxes at the beginning, and, as a care provider, you need to know what the focus of your care is or make sure that we're all heading in the same direction. So where do you think the whole responsibility for advanced care directives and conversations had? Our questioner said it should be the GP before they even turn up, but there must be some dislocation of general practice relationships when people enter facilities.
That will vary. So again, depending on where the person has lived prior to moving into a care facility, whether the GP can maintain the relationship, etc. Some may choose not to anyway. So again, there's a range of circumstances. But irrespective of who the GP is and how long they've been involved with that resident, certainly their role is crucial, and they need to be, the facility needs to be working in with that GP as part of the partnership, as part of the network. Ideally, they're in sync in terms of supporting the conversations and the considerations that need to be made by the individual and their families. And I think the other aspect in terms of aged care with the resident is we shouldn't be scrambling to do things all of a sudden because it's end of life. And we've talked about the importance of relationships and knowing the resident and vice versa. That should be happening as part of our good aged care anyway. And then you just roll into that next phase if that's so needed, and obviously tapping into specific resources that might be required, but it shouldn't just all of a sudden start because Mary's got to the end of life. Yeah. It's got to be something that's created from day one of that person's engagement with the service, and then maintained and hopefully enhanced through that relationship.
And I think it's already come out that it is that broader community conversation, and there is individual responsibility for all of us to be taking that on, that streams it through. I think it was the recent Productivity Commission report or it might be another report, there's a lot out at the moment, that was saying how quickly they wanted aged care providers to do advanced care directives when people come in, and it's absolutely right to say it's, that can be very confronting and not the right time, and there needs to be sensitivity and flexibility around that. So that sort of broader community, how you work with GPs all the way through life, is really important.
And I think that consumer-led movement is getting quite strong. One of the things I'm also involved in is being a clinical governance advisor to the Australian Digital Health Agency, and of course there is an option now to upload your advanced care directive into your My Health record. Fantastic way of just, uploading it and having it there so that when we start to have that conversation, reference can be made to it. My dad actually is right into this. He's got a My Health record. He keeps personal health notes. It's almost problematic. But he sent me an update recently. So he's very thorough, and Mum's got one as well, and we've been to the lawyers and we've got it all sorted. But he'd said that in the event that he should require an amputation, he'd prefer not to have one, thank you, and several other specifics. But I thought, that was something I'd never thought of, so I'm glad I know that. I'm hoping that we never have to have that conversation or make that decision, but he reminds me of the people, we are seeing an increasingly informed older community. We shouldn't think of everybody as sort of passive recipients. So consumers are leading us to be alert and to ask the right questions and to then respond to them in the very best way that we can. But I think that hopefully that the My Health record will provide us with another option there, and there is a break glass option there too. So I just thought I'd mention that because it gives me some hope. Maybe I'm biased because I think it's a great thing. But.
Well, you clearly know what to do about amputation. It's very easy. Mary gave us some insight into the Maori culture, but for Australia with other culturally and linguistically diverse groups, with a large ageing Italian population in South Australia, Vietnamese boat people, advanced care directives and conversations about end of life are maybe not quite as straightforward as they are for your father. Is that an issue for managing? Look, I feel like I'm saying a lot here. We've done a lot of research in this area with actually around an extremely culturally diverse workforce. Yes.
About 60% of our staff at North Adelaide, for example, which is just not far for people from out of town, just not far from where we are now, were born somewhere other than in Australia. So it just adds to the rich tapestry of services that we provide, but it does mean that we have to have different conversations about what's usual and what's different, and address language and think about how we describe things, how many acronyms we use, and not to assume that people understand. So we just see it as a great benefit that we have a cultural diversity in our community, in our residential group and in our residents, but and I think we're becoming much more sensitive to that, and thinking, there's always that debate, are you culturally, specific or generally culturally responsive. We're always testing ourselves, but I think diversity right across the continuum is very much where we are.
So why don't we just see what you think about how confident you are in discussing spiritual issues. You've had that poll, I think, or it should be there for you to... so we'd hope that was how it was in a palliative care conference, but still a whole lot of people who aren't so confident. What do you think about that, Ilsa? What should we be doing?
Fantastic, and I think if we ran the same poll, and maybe Pat at the ACSA summit coming up, we could run that poll and see how it compares.
We could.
Because our experience is that a lot of people are not comfortable talking about spiritual issues in aged care, largely because they haven't had the chance to even think about how they might do that, because it's not a core part of curriculum, and the organisation may or may not support engagement sort of explicitly in that space. That's in community and residential aged care. The community care common standards don't have anything specific around needing to understand people's spirituality. It's sort of in broad terms. And then in residential aged care, there's what I refer to as the dreaded 3.8, cultural and spiritual, which can be met by ticking a box. So, are you religious? Yes, no. If yes, which one? Tick. Okay, standard met. So there was a comment before about quality care, and certainly the standards around quality spiritual care just aren't there. But the fact, we have to start with a workforce that are comfortable in that terrain. So that's very encouraging. But of course, what we would hope at a palliative care conference.
We would hope they would. Yeah. And we'll get Virginia to get on with her microphones, and so you can ask some questions. But while we do that, let's do the poll question. What do you think are the greatest gaps in palliative care delivery at the moment in the residential care sector? Is it access to medications, equipment? Is it the training? Is it the communication? Is it emotional support for the actual facilities as well?
I think we need to say too, Greg, and I know Ilsa didn't mean that, but at all. But spirituality is more than religion. So here we are, and I know that because we've got this fantastic spirituality guideline. But so by ticking that, yes, we should have guidelines to lead us to the other conversations.
Yes.
Yeah.
And in this audience here, I'm sure that you would hope that spirituality, religion, and the understanding of the meaning of life and the struggle with existence is understood.
It is a cultural conversation.
It is,
yes. And it's a loaded word because there's a lot of assumptions that we know what it means. So for our staff, it's just that and not to diminish this hot cup of tea, but we have that conversation. A hot cup of tea in a really beautiful, fine coffee cup or tea cup might be something that makes a big difference to someone's life quality, right through to much more profound.
Yeah, absolutely.
Greg, just a quick comment around cultural diversity as well. I think another example are the different socioeconomic cohorts in our community, and just to give the sponsor of this session a rap, Decision Assist, they funded some programs in recent times, and we were a recipient of that in Brisbane, where we partnered with different organisations to provide palliative care to homeless people, and some of those people were living obviously on the street, some were in community housing, and the program enabled them to get great end-of-life care, some in our aged care facilities, some to other environments. But it was a good example of where there was obviously funding, critical element, great collaboration, and then some fantastic outcomes for people who otherwise would have been denied that sort of outcome. So there are great examples out there of good things happening.
Yes. So Greg, if I could just thank you for reminding me I didn't define spirituality, because of course we're confident having spiritual care, spiritual conversations. Well, what do we mean by that? So it's conversations about meaning, purpose and connectedness in people's lives, connectedness with self, with others, with creativity, with nature, and with something bigger, which may be God. So it may have a religious expression or it may not. So even if we're ticking a box yes for religion, what does that mean?
Yes. Indeed.
Yeah.
So let's have some questions from the floor, Virginia.
We've got the microphones. So, we've got one here, and then I've got a second one there. I'll come to you next, Roger. And don't forget, I've got my eye on you at the back as well. So I'm happy. My goodness. We've got a lot of questions. I need your questions to be short and sharp.
Hello, I'm Melanie Lovell. I'm a palliative care physician with Hammond Care, and we're providers of both aged care and palliative care. There's a lot of misconceptions around what palliative care is. We know that palliative care doesn't hasten death, and the evidence is strong that palliative care doesn't hasten death. Even terminal sedation, we know from systematic reviews, does not hasten death. How are we going to get that message out to our colleagues that what we do is safe and improves quality of life?
Is that an issue in your aged care organisations, that the stigma and fear of palliative care as a name and a service?
There's enough stigma around aged care as it is.
You've,
I don't think so. I mean, I think we're really quite good at it. I know that the perception isn't there, but in fact, one interesting thing, because I work a lot in the built space, I quite regularly get asked for palliative care rooms.
yes.
It's a thing. And that's, I guess, you know, I'm sure there have been talks about that perception of needing to separate somebody out to create something special. But the fact that I get those questions, I'm really grateful for them, because it gives me the chance to have that conversation about ageing in place and why we have 100% of single rooms with en-suites. It's like, so even with that, why would you move to this other room? So I think I feel that the sector is very sensitive to palliative care and end-of-life care, but also to living the quality life until the end. So at the pointy end, the conversations get more difficult. But I feel like there's a readiness.
And I'd support that, you know, right across the system.
Roger Hunt. Thank you, and I think this is a really important topic. I think we could fairly say residential aged care facilities are becoming slow stream hospices. The number of deaths in aged care is increasing quite rapidly. The length of admission is decreasing. In terms of cancer deaths, there are now more deaths in aged care in South Australia than cancer deaths in hospices and at home combined. So, and we need to look at what resources are available in aged care.
Got a question, Roger?
Yeah, we know that specialist palliative care tends not to be involved in cancer deaths in aged care compared to other settings. How do we get specialist palliative care involved and all the other resources from GPs, nurses on the floor? How do we get make nursing home proprietors accountable for the number of staff on the floor rather than taking profits from the taxpayers' money?
That sounds like there's a fair bit in that question already,
Pat,
so I'm
do you
cutting you
wanna
off.
Make a comment?
So first of all, I think it's a really good question, and it's one that, you know, perhaps ACSA and Palliative Care Australia should work with together, because there'll be a range of different barriers as to why that doesn't happen, just as there are barriers to why GPs sometimes won't even go into aged care, or why we have difficulty getting GPs. So I think, you know, that's something that we should work on across aged care and palliative care around how do we do that. Some of it could be because there's government regulation that, you know, prevents it. Some of it could just be that there's misunderstandings between sectors. So I think that's a good piece of work. Aged care providers actually are accountable for the number of staff that they have, both through legislation and through accreditation, and there are regular checks of that, including unannounced visits. So it's not true to say that there is no accountability of aged care providers. In fact, there is accountability of aged care providers. But there is also, it is designed to enable aged care providers to be flexible, because the needs of their residents change, the makeup of their residents change, and as I said, what the requirement is around the right level of staff and the skills mix, and I think that's absolutely how it should be, and providers are accountable.
Good. Let's move on.
Jane, one of my hats I wear is around prisoners, and I'm just asking the question, where is palliative care fitting with our ageing population in prison and access to palliative care?
So do you have many prisoners in your aged care facilities?
I call them residents.
They call them residents, yes. So it's a really important topic, Jane, but I don't know that prisoners fit with residential care or aged care services. They're one of the most vulnerable people and groups in our society, I have no doubt.
It's certainly not something I know the answer to off the top of my head, but maybe it's something we could look at.
It was about
prisoners.
Prisoners.
Certainly in New Zealand, hospices provide support to prisoners, both when they're incarcerated, but also they have been released to hospices for the last days of life.
Yes, and I know in South Australia we have protocols that are well developed because there are deaths in custody and there's a whole other raft of things that happen. the mere fact that you're a prisoner means that some part of your liberty's been deprived, and so it's I think that's an excellent topic for our next conference.
And
really.
I'll just say, I don't know if Professor Starr from Flinders University, I don't know if she's in the room, but has done postdoctoral studies on ageing prisoners. So there is a lot of expertise in this state in Professor Starr's work. So it is an interesting area, and I do know some people who work in the prison system, and the number of pieces of assistive equipment that are required, and the way that, a bit like in America where the disability access standards very much revolved around wheelchairs, some of the design features of our prisons are not particularly age-friendly, but you could say the same about our hospitals, but we won't go there.
Yeah, we won't go there.
And just to say also, Bruce Stevens at Charles Sturt has also been doing a lot around ageing prisoners, so there's some thinking happening out there.
Yes, but I think that's a really interesting topic to explore further. We've got another question.
We've got another question just here.
It's not really... Can you hear me?
Yes.
It's not really a question, it's a statement. I am a volunteer with the Calvary North Adelaide Biography Service, and we would love to be working with all of you. We give the patients the opportunity to tell of their lives. We don't ask questions, we sit and listen, and they open up and tell us about their spirituality, about what has meaning in their life. It enables them to speak about death openly. And because we're not medical, they seem to open up.
I think that tells us the essence of volunteers equally, and I'm sure your organisations have many volunteers, and it feels like an indictment on medical people, but volunteers bring the man from the street, they connect, don't they?
Absolutely.
And biography, life review, what's the meaning of my life and where do I fit in the context now and where have I come from are all really important things, aren't they? Would you like to talk about...
Only to acknowledge that there are many wonderful volunteers in aged care, both residential and home care, and they're a really important element of the service. And as you say, it's another person that you can talk to. It sometimes takes it out of that professional or medical setting. So they're absolutely critical, and there are many of them in aged care, and we appreciate the work that they do very much.
Got a question here.
I'm Peter Jenkins. I came from a public health service where you just share everything when someone asks for resources, into not-for-profit, and I'm sure for-profit aged care is the same. There's that fine line between maintaining a competitive advantage between organisations and the fact that we're all in it to do the common good. Palliative care specialist services, I think, are growing, and Palliative Care Nurses Australia has an aged care special interest group now. But I just wonder, from the aged care industry's perspective, whether maybe through the peak body we need to be able to get together and just share, because there are so many organisations doing so much good. Why try and recreate the wheel?
It's a really good point, and we do, I mean, earlier this year I was really privileged to launch some guidelines that we worked on together with Palliative Care Australia and Aged and Community Services Australia, so we're the not-for-profit peak body, but we also worked with other peak aged care providers, and it's a really good point, and I know Liz Callaghan really well, and certainly ACSA is really keen to work with palliative care. It's a really important area, and I take your point, we should, and we will.
Just a quick comment in relation to that. Absolutely agree in terms of fostering more collaboration. I think there's a great opportunity in the home care environment in terms of palliative support.
Yes.
I think we should be looking at some funding around those specialist palliative services because we haven't spoken about it too much today in terms of end-of-life care in the home, and obviously increasingly people are being supported to stay at home and obviously choosing to stay at home where they can and will want palliative care in their home. How are we going to best deliver that? So the sort of collaboration that we're speaking of is absolutely critical to make that happen as well.
Make it seamless across the
and I think that's a huge area of sort of a mismatch, or it's a developing space really, isn't it? How the aged care provision at home interfaces with specialist palliative care and community nursing, and how we have a seamless, supported service.
And Greg, there's probably some examples to look at in the UK where more happens at home in terms of necessary resources, whether it's beds or other aids, are brought into the home, whereas here we tend not to do that. Not just in palliative care, but in other spaces as well. But obviously, from our point of view, that needs to happen in the palliative care space for people who are in the community.
And even within Australia, it's vastly different at state level. So WA does much more in terms of supporting people at home than, say, some of the eastern states. So we've got some work to do.
And I think that there might be another, the nature of hospice is changing, the amount of time that people spend in hospice, the number of people dying at home instead of in a hospice space. I'm really quite interested in this. We're supposed to be expert generalists in residential aged care, but is there actually room now for some other kind of specialised cluster model where people living hoping to die at home can partner with, organisations can partner together to provide some specialist services in the residential and community care context, so as a continuum, but outside the hospital loop. That there are special spaces that are unlicensed and additional, and we've done this before. We've had a 10-bed short-term unit at Mawson Lakes that we built, but there weren't funded beds, that people could come in, bring their carers, bring their family, attend medical appointments, go to the pizza restaurant, come back. A different kind of, almost a hotel-like model, but where you can come in and go out, and those transitions across the sectors and from home and back.
I think the key thing you said there was it sort of has to be done as unfunded and separate from the system, and what we really need is for the funding systems across aged care and across health to actually allow for those things to happen, because then we could do it much more routinely.
And the innovation, absolutely.
Yeah.
Greg, I've got one more question for you. I'm on your right here. If you think you've got time, I've got another question for you. Up to you.
Mary, did you have something to say?
I just wanted to talk about the model in New Zealand where hospice is very much in the community, so it's not a building at all. It's a community service, and most of the care happens in people's homes, and that might be residential care or that might be in their own homes. And the inpatient units are... people come and they go, and they come and they go, and only a quarter of all hospice patients actually ever go into the inpatient unit. So I think we do have quite a different model that's very focused on community.
But I take Pat's point that if we had flexible models where people could come in and if there was a funding structure to support it, I think of people from the country equally who may need a physical surrounding but don't need all the other things. Let's have one more question and then we'll wrap it up, I think.
Hi, my name is Anne-Marie. I'm a clinical nurse consultant in PALCare at North Shore Hospital in Sydney. Recently I was asked by Australian Catholic Care to educate new graduate nurses about palliative care. So that was really exciting, but the main thing they wanted to know was how do they talk to families? They didn't know, and they were very frightened by this. So my question is, what in terms of education and support do you provide all of your staff?
Okay.
Oh,
Marcus, you want to talk about your facility?
Sure, thanks, Anne-Marie. Probably difficult to answer without trying to boast, I guess, but
You're allowed to boast.
we're pretty comfortable with the way we support our workforce in I guess, maybe a holistic way is what you're alluding to. So that's leveraging expertise of different people in our organisation, as well as bringing it out and sending them out to the wider world as well to learn from the right people. We tend to find that they are really strong at building personal relationships and establishing trust with not just the resident but the family as well. So when the difficult moments arise, you use that relationship and trust to talk through it, work through it and find a solution. So that's obviously from my own organisation's perspective. I think the question before about there used to be better sharing of knowledge, and I think that's something we need to foster, because I know even at some of our industry conferences we hold, organisations are reluctant to stand up and talk and share what they're doing, either A, because they don't want to be boasting, or secondly, they want to keep that competitive advantage. So I think there's some of the barriers we need to work over within the industry, so we're better sharing our good ideas and good practices.
I think also we try and work with all the team. It's not just nurses. Nursing homes, that term shouldn't exist because they're not nursing homes, they're residential aged care facilities. But many of the beginning questions around palliative care and with families start from the admission process. So we have an amazing team with a really interesting skill set. We have a social work team, so there's a whole of organisation approach. But we're also piloting something interesting at the moment, which volunteers can use and our care staff. It's a very ground up called the Top 5, where we ask residents, what are the top five things that matter? What are the 5 things that are going to make a difference to your life, and how? Yeah, and then we share them. and we have a pay it forward process. So if we learn something that makes a person feel happy, then we make sure we tell the next staff member that's coming on, this happened, and so we pay it forward in that time. So it's a really simple thing, but a good way of
And so really we're talking about honouring people,
Yes.
person-centred care, about communication, and you know the other core issues of what we would call a palliative approach around person-centred care, symptoms and addressing the needs of the person and having good communication. And I think if this panel hasn't said anything more, there's a need not only for our residential care providers and aged care providers, but our whole community to be better at talking about death and what we want, really. So I'd like you to fill out your feedback forms. Please give us as much information about what worked for you and what you thought was good and what we could do more. I'd like you to thank our panel. Thank you very much indeed.
Thank you.
Thanks so much. And please thank Greg for wonderful moderation of that really great panel. Thank you all. And thanks for your great contribution and some terrific questions. We have lunch now for you, midday until 1 p.m. Then you've got your concurrence from 1 p.m. until 2:30. Then we're not